Hello, everyone. Welcome back to another episode of the Neural Medwork. Michael and I are very happy today to have Dr. Alaa Youssef join us from the Stanford Center for Artificial Intelligence. Today we're really going to dwell into a lot of very interesting topics, including Dr. Alaa's paper on the organizational factors of clinical data sharing for healthcare. We're going to talk about education and medical education and how we can implement that in an era of AI and how we actually implement some of these tools in hospital settings and clinic settings in the clinical environments that we work in a safe and an ethical way. So very, very excited for this conversation today, Alaa and Michael. And I just want to provide a brief introduction to our audience about Dr. Youssef. So she's a postdoctoral fellow, as I mentioned, at the Stanford Center for AI in Medicine. She finished her Doctor of Philosophy in Population Health and Medical Education from the University of Toronto in 2020, and her research interests lie in the intersection of AI implementation and clinical evaluation. And she's published in some very top tier journals, including JAMA, which was one of your latest papers, which I read, which was really, really eye-opening and really was the impetus for me to contact you on LinkedIn to get this conversation started. So I guess that's a good place to start. Do you want to tell us a little bit about that paper you guys published in JAMA last year and what really made you focus on that topic of clinical data sharing and how we do it?
Yeah, first, thank you so much for having me. I'm really excited to be here and having this conversation with your audience as well. I think the main component of really what drove me in was, and the motivation was, recognizing that Stanford is sharing data. The Stanford AIMI Center has a lot of sharing of data, but it is important to recognize that as we talk about AI deployment, we face the challenge that models are not fair because the data is not representative. And so as long as we don't have data that is representative of the populations, we have problem of building reliable models. And so there has been a challenge of if you want to build an equitable AI ecosystem, you need to have data that's representative of that ecosystem, including community hospitals, large academic centers. But what we have been seeing from research is that most of the public data sets are coming from Ivy Tower institutions. And so we see a certain type of data sets, and majority of the other types of data sets that we don't see is where algorithms are unlikely to perform well. So a question that came up is what makes organizations willing to share or not share, and why? You can think about what is the motivation that makes some organizations like Stanford or others, or MIT, for example, that have released Mimic, willing to share and others are not. So that was really the core motivation to understand that. And the reason of it was to understand if there's specific patterns across sectors, if there's specific barriers that we need to address, and if there's specific ways that organizations actually collaborate well on that we can enhance and foster in order to improve data flow. You can think of data sharing as important because you need data to flow from when it's acquired by the patient to when it gets to the developer and then finally to the patient back again.
Yeah, and that's so interesting because, in healthcare, we have to talk about how much of our data is not used. Most of the data that hospitals and big university networks have is sitting there in the EMR and completely untouched, and the learnings from that data have not been utilized to date. And so finding a way to utilize this almost gold mine of data that we have sitting there in a safe and ethical way is such a big part. And certainly in building any AI models, it's garbage in, garbage out. And the better data you have, the more representative it is, the better your outcomes are going to be. So I'd love to hear kind of what you found from the interviews you did from, I think it was 18 different organizations, right, that you touched base
Yeah,
with?
yeah. So to give a quick overview, the goal of designing a cross case study was, can we look at the different sectors that intersect in the healthcare ecosystem, including academic, government, nonprofit, and private. And you can see nonprofit organizations, for examples, that are assuming the data broker role, where their role is to aggregate the data and share. There's academic or there is private organizations that their role is to collect data and whether ethical or not is to sell or share that data with AI developers who require data from multiple institutions. There's the government, where yes, the government is not the acquirer of the data, but it does a lot of funding initiatives to bring data sharing initiatives, and that has included, a lot of things that has happened during COVID-19 that has led to the like development and scale up of AI research. And then there's of course the academic organizations, which is the biggest category of where data is acquired, because most of academic organizations are linked to health systems, and they also have the scientific and research as part of their mission. So utilizing the data to get into research is really important. So just to get back, where we're talking about those four different sectors. So we selected organizations. The organizations were selected based on organizations that share and organizations that are resistant to sharing. So we tried
Mm,
contacting many of these organizations, and of course organizations that are resistant to sharing was harder to get into. But what we have learned was really interesting, because we were thinking that any organizations that have the capacity to have AI infrastructure should be willing to share data. And what we found is
mm,
actually what motivates organizations to share data is whether the organization itself is motivated to share data. So if the leadership, if the organization is investing, if it sees data sharing with the public as part of its mission, and part of the
mm,
value that is gaining, that makes organizations putting into the infrastructure and to support that, and say we are supporting this effort. Because we know that data sharing is the problem with data sharing is it's really extremely hard of a process as well as expensive. So quoting one of the interviewees, there is almost a stop sign at every stage of the data cycle, from where it can get to be acquired to where it can get to be released and shared safely. And so if you don't provide infrastructure and resources and incentives to make the process flow, then that process is going to stale at one of the stages. So to get back, there were two main components: organizational motivation and organizational readiness. And so organizational motivation required how much of data is a priority for this organization. And you could see, for example, academic organizations might be interested to share data because it gets research and it gets them to reputation. So it becomes known that these organizations are sharing data and they are also producing top tier research on AI, for example. Other organizations, interestingly, might not be interested to share because they don't want to release this to the public, because they want them themselves to be the first releasers of this knowledge and to show that they have leveraged the data. And our hypothesis is many of the organizations actually are holding onto the data because of that component. Beside privacy, is that if we can benefit from it, we should be the first to publish on it. Now, this paradigm has been fortunately shifting, so that's great news. But I think there's some of that still bending. And then the other component was organizational readiness, which means what infrastructure do you have? Academic centers have AI experts have IT infrastructure that allow them to get the data from electronic health record and have a process for data identification. They have a robust governance and privacy that allows them to develop their contractual agreement, whether with other organizations or the data use agreement to be used. And then we recognize that there was also the human resources, where having people who are experts in not only the data science aspect of it, but people who are experts in the electronic understanding the different data models, who are experts in providing clinical feedback, how the data should be labeled, what variables should be coded. All of these were important components. So you also have to think of that human resource dimension. What is your organization capacity and human resource skill and expertise? And
yeah.
yeah.
Wow, that's so interesting. That last piece, especially, when I think about our hospitals in Canada, at least the ones that I've worked at, we just have enough IT professionals to kind of maintain our EMR, deal with the day-to-day IT infrastructure that needs to be dealt with. But, to have a team of data scientists that work on something like this is just not something that hospitals have capacity to do. Like they don't have the staff to pay for it. I've had conversations with certain hospitals I've even worked with where you talk about AI. The biggest barrier that I hear from some of the chief medical officers or chief medical information officers is that where am I going to get the time and the personnel to do this, because my staff is just bogged down in the day-to-day IT service of making sure that the hospital flows. So it's interesting. In the States, do you find that there are a lot more data scientists in these organizations where you were interviewing people?
So it really depends on the organization. But just to add to this point, it's one of the major factors with AI development and deployment is all health systems are pretty taxed and are are overburdened with a lot of cost and clinical care needs that they do not have the capacity to free up of their IT services because they actually need more. So what happens is if you don't have the mechanisms and you dump more onto the already burdened systems, you get to have a fail down of everything. So to prevent that, if you don't have the capacity, it's unlikely that someone is going to support you to add more of a burden on infrastructure and IT. With respect to states, it really varies depending on the organization and again, like their role. If their role, for example, you can see one of the big initiatives in the United States is All of Us. So it's a government NIH funded. It has really invested in building its infrastructure, and it really has invested in how data is being acquired. And so, depending on similar components, similar funding and government initiatives, you can find that infrastructure. In academic organizations, can find them based on like what is the type of research and top tier of the academic centers. Are they publishing? Are they or they are just are they associated with the health system? And then the third component relates to private, which is also plays a huge part in the component related to acquiring and collecting data. So I think there's a lot of variation, and this is where we are trying to put the spotlight. There's some people who are going to be at the front row of being able to build and develop, and there are others that are going to fall behind. And really, one of the main components, if you really want to advance equitable AI, is us collectively coming to think together about how can we support the under-resourced health systems to really be at the stage where they can participate in data sharing and algorithm development.
Yeah, so just that was very intriguing conversation. And I love the inputs. So just to sort of reflect on, what we talked about, it really reminds me of resembles the debate between open source and closed source AI model development,
Exactly.
in which you look at OpenAI, they're like, I want to be the first one to, push our models out. But then you look at Meta AI and they're doing open source in which they invite everyone to contribute to the system. Now, one question that I think you touched upon is when I think about data sharing, especially in terms of like equity and sort of like underrepresented communities, I think about like, are these data actually collectible in the first place? Because if we think about underrepresented communities and if we think about rural areas, they might not even have the digital infrastructure to facilitate the sharing of these data. Now, in our case, if we want to solve some of the bias problem in things like large language model, that the requirement for these data for data coming from those underrepresented communities is huge. Like we're not just asking for a little chunk, we're asking for all of them. So how would you see like in the future that sort of like what's the required steps and what's the best for achieving that in terms of getting these data out of those underrepresented communities to actually facilitate the training of ethical AI?
Michael, this is an excellent and really question. It keeps me up at night thinking about because we know, the algorithms are not biased because they're biased. We know algorithms are biased because our data is biased. But the main challenge is we tend to think of AI to improve health equity or to promote health equity without thinking of that we need to invest in addressing the systemic and structural biases in our health systems that lead to those inequities. Because simply put an algorithm to detect diabetic retinopathy, it is really helpful if patients are coming to the clinic. But if patients are not coming to the clinic for their diabetic checkpoints, then really we're not capturing them. And this is the problem. If you drill down on this, people tend to be like people have jobs that are 24/7. They have shifts, they can't really afford time, they wouldn't go to care unless it's really necessary, and so they have a higher progressed disease, likely have higher severity, and really are unlikely to be following in their appointments and coming up regularly if they have like other burdens. We see in Canada a lot of things related to drug affordability. And so, like there's so many different factors that we really need to consider in order to ensure we are collecting the right data. And then you can actually see again, there's positive examples to learn from. We have seen that there is examples where actually consortium of data provide credits and expertise to help under resource setting to have the infrastructure of encoding their data and putting their data within the consortium of data sharing. So it actually requires that also on us as health systems with resources to reach out to health systems that are under overcapacity and see how can we initiate collaborations and support them, because they are very eager to be part of the AI ecosystem. They just don't have the resources. So it's a much broader conversation that requires players at the government level, academic centers, and like entrepreneurs and all people to kind of like think of talented and incentivizing ways to bring us together.
And it almost
Yeah.
seems like to truly reap the full benefit of AI in healthcare, like one of the biggest factors to look at will be unlocking this potential of making sure that the data that goes in is one that is very inclusive and comes from, all different sorts of institutions and even countries, right? We know that, for example, Google has done a ton of work in India with some of their models that they developed with the diabetic retinopathy, but there are going to be parts of the world that they don't have the infrastructure to put in the data to some of these proprietary models. And so how well is it going to work in those places? And if it doesn't work well, then are we increasing that marginalization of a population by pushing forward with AI?
So I want to, like I 100% agree, but I also want to say how I appreciate, the role of industry in being able to scale up. And actually, they're doing something that's much better than us, where they are doing multiple phase studies across the deployment. So learning from, and not only from the study, but from other studies about how they have stages in terms of like their studying and implementation of an algorithm is really what makes them able to have products that can be scaled up. And I think there's a number of ethical questions about whether is it ethical even to use AI just to access specific marginalized patient population. But you also have to look at what is the context of care, and are they already having access to care or not? Is that any better than what they're already receiving? And so, like I think there is lessons to be learned. I think that just like back to what Michael is saying, we need an open culture where like Hugging Face, put your models on, be open
Mhm.
about what you developed, let other people reproduce, and know that when you're part of the open conversation, you're more likely to benefit from the like from the collective community of participants, whether academic, government, nonprofit, and profit versus if you're just hold on to everything and just really don't want to release anything, because this is, I think, the main problem with treating the competition in AI in healthcare industry. It becomes like we have unlike traditional markets. Healthcare is a unique market where we're not competing on what is the best model, we are competing on who have the data.
Yeah. Yeah. I I absolutely love the idea of sort of open source healthcare community, and I love that the fact that it really a lot of people are aware of that now, and that's why we're here to talk about this, and we're spreading the awareness of this future that we're building together, in order to help our physicians to actually help with the healthcare system and the problems that we're facing in healthcare right now. Talking about physicians using AI technology, I want to shift our focus now to sort of like the educational part of healthcare and AI. So the first question that I have for both of you is, what are the basic skill sets and traits that you believe are necessary for a physician in today's era to fully leverage our, most state-of-the-art AI solutions in healthcare?
I think one of the things that I come back to, which the NHS published in 2022, was kind of the different roles that people can play in healthcare AI, and they defined it as shapers, drivers, creators, embedders, and users. So I think the most intuitive one is obviously users. So anyone that uses any AI technology in the clinical workplace has to have a certain set of understanding of the product that they're using, just like you would in real life if you were using a product, to know what it does, how it does it, what its limitations are, and how can you use it safely. And then there's going to be other roles. So people like embedders are going to be the ones that actually monitor, evaluate the AI technologies that are put out, for example, into a hospital setting, to make sure that there's a continuous quality improvement piece to make sure that things are working well. There's industry, as you talked about, with creators actually making models for us, or AI related healthcare products that we can use. And, they have a bigger level look at things to say, what are the problems in healthcare that AI technology can solve. The drivers would be kind of like your local champion if you're rolling out a product like they did at Kaiser Permanente with the ambient AI scribes. They had champions that would go around the hospital that would help increase the uptake and educate people on how to actually use that product, for example. And then the last one they talk about are shapers, and that's more the high level policy governance people that are involved in those conversations with the FDA and with different organizations to say, this is how we can do AI in a safe and ethical way, and make sure that the guardrails are in place for this sort of technology for all of us to be used. And so I think as a healthcare professional, you have to ask yourself, what is a role that I would like to play? And it depends on someone's interest. I think we're all going to be users at some point in the near future. Maybe that's 1 year, maybe that's 5 years. But the other four categories, I think it depends on someone's interests. And obviously the training required and the experience required for each of those depends on what you want to do.
Yeah, and just to add on that, I think it's really important to recognize that there is going to be a set levels of basic competencies with respect to users of all levels. So I think the number one is we're going back to fundamentals of medicine as healing, where how are we going to use the technology responsibly to ensure it's in the best interest of the patient, and continue building that relationship. How do we train our physicians to almost be bilingual, to be able to use the technology but also able to listen to the patient, to be able to practice their judgment on when to put the guardrail, to say no, I'm not using, or I'm using this algorithm. To be transparent, we see a lot of different perspectives in interviews about whether patients should know whether AI is in their care or not. And so helping physicians understand the different types of ethical questions, workflow questions, and things they need to be curious about when they're interpreting AI models as users is super important, because that then it makes them in control of feeling competent enough to make a decision whether AI is a good use and a good tool I use or not. I like to think of it like as if you are in surgery, or and you have different set of I'm not a surgeon or a physician, but you have scalpel, you have so many different things that you use, and you pick the tool based on really what you really were trying to do. And so the most important component is to recognize, what is the AI serving in my patient care, and also to recognize the risk of over reliance on technology and automation bias. And that's why it's also important to, as physicians and people who are involved in AI development, to really work with developers of AI to say, oh, these are the things that's important for clinicians to know, and this is why, and this is how it should be communicated. You can take a question about the prevalence of disease and how much the model is confident. At different diseases, the threshold of what sensitivity and specificity is acceptable is going to differ. And so are you telling me by moderate confidence, is it confidence based on the prevalence of the disease? Is it confidence based on the, based on the data it has seen? And so these are the type of questions we really need to think about, and not to burden curriculums with, of course, understanding fundamentals, but recognizing that there's another level of skill and tool sets we need to physicians to develop as they are in their training in undergrad and fellowships. And last point, with respect to leadership in medicine, I think we will look for, like, we academic organizations needs to invest in having training programs to train the next generation of leaders in medicine, who are really going to, as Samir mentioned, put the guardrails, participate in policy decision making, like be at the forefront of championing AI and taking the lead and educating their team and being able to be good leaders and good models. So I think these are important things we need to still think about in medical education.
I'd love to get your guys' viewpoint. Like when I look at the literature and, look at a bigger picture scope on this, is there are, for example, medical schools. When I went to AI Med last year, where they were presenting, there were medical schools in China where medical students actually learn how to code. They learn how to do foundation model building in medical school. It's part of a core curriculum. And then there's obviously places, most places in the world right now, where AI is not part of the formal undergraduate medical curriculum. So it'd be interesting to get both of your thoughts on where do you think the pendulum should land in terms of, do we need medical students to really get to the nitty gritty of understanding coding and those sorts of aspects? Or is there a middle ground? Is there a course that should be taught in undergrad? Or is it more of an application type, fellowship, or an application type learning that should happen in postgraduate education, as a lot of physicians learn about how to evaluate research papers, because as you are going to work in clinical settings, you need to know when information changes, and how you evaluate that is part of kind of every postgraduate training program and even within med school. So would love to hear, especially Michael, with your background too on computer science, what you think would be a good kind of balance.
Yeah, so I think what we're seeing, especially in today's sort of coding space for AI, artificial intelligence, is that we're seeing that the requirement for coding skill is actually getting lowered and lower for using artificial intelligence. I'm not talking about, developing the best or the state-of-the-art model. I'm talking about developing using existing technology to facilitate some functionality in the healthcare space. That requirement for coding skill is actually getting lower and lower every day. We're seeing, startups doing no-code AI developments, no-code AI agents development, no-code, like take the example of the OpenAI store. You can easily develop your own clinical sort of GPT in that sense without any coding skill. So to answer your question, I think the coding skill required for, people working in healthcare to actually use and develop different features for their own clinical practice is lowered. And I don't think the bar is going to be raised. I do not, think that it should transition to a course of, you have to be a computer scientist in order to, do this role. But I think the transition is to leverage the new tools out there, to fully leverage them and understand how to use them and develop, key functionality to support your personal need. And that space is where I think education becomes even more important than just learning how to do Python. That's my personal take on this. I want to hear, what you guys think about it.
100% agree with you, Michael. I think also there's something about, like a physician job, like if there are people who goes into medicine and they really have that computer science talent and they really want to do this, and then they're, of course, they're at the forefront of doing that, but they are assuming, Samir, what you talked about, they're developers. They're not only clinicians, but they're also developing and putting, shapers of what this technology is going to be and how it's going to be implemented. But not everyone gets into medicine with the same interest and with the same level of background. And I think, again, it's easy there's a big question of, like, how much can we insert into curriculum when already curriculum is condensed and the timing is very short. So purpose people go to medical school is to be experts in medical training because they are the doctors. But the most important questions is, what are the critical questions you're going to train them to ask themselves about AI algorithms, to know how to select good AI algorithms? I can tell you that how many, like if you do a market scan of all of the AI that exist, I'm pretty sure clinicians are being, approached by thousands of vendors. How do they select which is the good ones? What is safe? What questions do they ask? And then if we come even back to the component of coding, whether it's coding or not, I see there's a very big value of collaboration between experts in coding and experts in medicine, because one component of it is, the problems for coding is just you're not going to get a model and recode, but there's a problems of translating research into operational knowledge. And so you have problems with acquiring things from Epic and interface. You have problems with IT, and so you have different forms of different questions that you need to think together as a team: clinicians, ethicists, developers, and machine learning scientists, and then define an approach. And so I think losing sight of that collaborative knowledge is a missing point, because it can lead us to develop solutions that are not either deployable and helpful, nor or they like they're not addressing a clinical need, or they are not accurate enough.
Yeah, yeah. I mean, I think that's the key. I think the best products certainly understand what the problem is that they're trying to solve, and no one understands a clinical problem better than a clinician. And being able to translate that to someone who is in med tech or technology, or an engineer or a computer scientist, so they understand the problem together and find a solution that's practical, is obviously the best way forward. I mean, I think another thing that really excites me in terms of where AI can be used in medical education is just almost like using AI to help you learn. For example, I'm doing my master's in AI right now, and there are some concepts that are quite challenging that I quite frequently go to ChatGPT and just talk to ChatGPT about the content that my professor put on a slide that I didn't fully understand. I just go back and forth with it until I get a better understanding of the content. And I think, maybe implementing AI tools from the beginning to aid students in their own learning process might even make them more comfortable using this technology when they're out in clinical practice, because they've had some experience. I mean, certainly we need to make sure the content is proper and there's no hallucinations and stuff like that. But I think there's one piece about having students and physicians understand how the technology works, but the other is just allowing them to use it in low case scenarios, like sitting in a tutorial group talking about made up cases in a safe place where there is no real patient and no one's going to have a bad outcome, but they can just really ask questions and be open with something like an AI. I think would be also a very interesting use case of it in med ed.
I really kind of like the idea, but also want to kind of like flag something that I think we are not understanding enough, or I'm really kind of interested in currently exploring, is our human biases in how we prompt large language models, and how this can shape the behavior of large language models as they operate in clinical care. I do think they really have a unique role in education, because even in elementary, even in like the way they facilitate and really kind of democratize access to training and education for not only for everyone, it has been transformative, and the productivity they bring in is really impactful. I guess the main component is, how do you develop, and this is something I struggle with personally, but how do we develop the ability to be able to leverage the technology to our best, yet to allow it not to replace our critical judgment, and be able to kind of like really develop the knowledge, because you can think you can know something until you are approached with the problem, but because the way you have learned about it might you might think you understand it best. But I have seen in chat gpt and other platforms how really it can explain the concept very well, that you really do well on assessment, because you really understand the problem well. You really understand, imagine, like having, like, used always to struggle with, like in textbooks when they have like the answer key for only the even questions and not for the odd questions. And when I was stuck with the problem, like, so what do I do? Now I feel like, okay, like I can have someone to talk to. And so this is like really where it is. And again, Samir, like what you talked about, many people, even in medical schools, they are allowing students to use that and come to the class to kind of discuss. And this critical reflection is the main component of learning, is like, where did the technology did not really provide the comprehensive component we needed it to? What does that mean for us? And where can we be using it, and what type of question should we be asking?
Yeah, I really, the example that you gave me, that you introduced, really sort of like made me think of resembles another sort of like experience back in middle school or high school where you have question when you're in math class, you have questions that allows you to use calculator, and then you have questions that you cannot use calculator with, right? So going into college, you have exams that are open book, but then you have exams that are closed book. I think it's in a sense that allowing, especially generative AI technology into the educational realm is very similar to this idea. It's not about using it or not using it, but it's about like educational content on which it's allowed to use, and then in other areas where we have to sort of ban the use of these technology. And we don't have that framework yet. We don't have a textbook or question set or exam that's suitable for that use. But I think it is very interesting future or direction to explore in which we have the combination of the two. That's just something that popped out.
Yeah, that's a really great point. And I just quickly to add on this, I think it really emphasized the need to, for us to revisit how we think about education and curriculum and pedagogy, and like what are the instructional designs we're going to be using in class. What is really the goal of like I think it's always interesting to see that we sometimes get bogged down with the process or with the topic, and we lose sight of what is the need or why are we using this. And so like having the framework of when, at what time in the curriculum I'm introducing students to using ChatGPT, what is the role of it, how can you define that role. And so having these type of questions as framing at the end of the course, you can feel, okay, I have trained my students or my learners to be competent in this and this. I expect them to perform on the evaluation at these levels. Versus, we have a mix of didactic information, things we have been using, allow for technology, but we are not really understanding where and when and how it's being used. That where may things fall into the cracks.
And it just doesn't apply to medicine, right? I mean, this is a bigger question for all educational institutions. I know, for example, the Khan Academy, which is a massive platform, they've introduced their AI assistant, and if you listen to one of the TED Talks from their founder, Sal Khan, he talks about the use cases and how some of the teachers were really in favor of it because of its tutoring style, and about the whole two sigma problem, right, in medical or in just in education in general, about how if people do have personalized tutors, you can change the standard deviation by two sigma up, and every student becomes a much better student and a much better learner. So definitely a much bigger conversation, and well, there will be interesting medical implications for that. And I think all of education, whether it's grade school, university, high school, is probably going to be transformed in our lifetime with some level of AI.
Yes. So speaking of, getting trained on or getting education on AI, I want to touch upon another topic which is the deployment of these technology in the healthcare space. So we touched upon, who is qualified to use it, how do you use it how do you train them to use it? Now we want to touch upon a topic of how do we actually use it? How do we get deployed? How do these models get deployed in healthcare? And one of a very interesting question is from your experience, Dr. Youssef, was there any successful examples of AI models being deployed within, maybe Stanford hospitals or other healthcare settings?
So I think this is a really a question that all health systems are trying to answer. Not speaking specifically of Stanford, but there is institutions that have been able to deploy algorithms. But I think there has been more across organizations of realizing that, before embedding AI, you really need to understand the workflow. You need to understand how it's changing, because it's one thing to develop an algorithm, and it's another thing to have it inserted into workflow and to have people using it the wrong way or it not to be addressing the need. And then your data is drifting, so your algorithm performance decrease, or you have problems with how people expect the algorithm to be performing some tasks because they have not been trained on exactly what the AI is doing. and where to watch for pitfalls or blind spots. And so this is where we are collectively learning about where AI is like succeeding and where it's failing. And it's important to realize that like it's also, you cannot, like, I think at Stanford we have developed the data science team at Stanford Healthcare has developed something called the firm, which is fair, usable, reliable, and measurable. But if you think about it, you need to assess it, to assess any use case based on what is your need and problem that you're trying to solve for. Does the algorithm provide that? If it's coming from a vendor, what sort of questions do you need to ask about how the algorithm was developed? And there's questions about financial component, because we're not going to be able to like implement all AI solutions are expensive, and so we need to have a vision of what is the value proposition for using to invest in tool A and not tool B. What is the trade-offs I'm bringing to patient outcomes? What is the trade-offs I'm bringing to clinicians before kind of like putting in or investing in AI? I have seen in radiology in private practices to be a lot of learning lessons of how they really deploy AI and learn where it fails, and also train clinician on cases where the AI fails and show that AI in the human is much better than the human alone. We have seen research that's showing that, when you support human and clinical readers with AI, their collective competency, I would say, is better than one alone. And so I think recognizing really those use cases is still something that is being developed, is being recognized. But I think mammography is one of the top in terms of like, there has been a number of randomized control trial is showing that, if you pass the algorithm to read whether and score a breast image mammography on whether it has cancer or no cancer, and then initially you needed to have it paired with the radiologist. Now they're showing that actually you can surpass that, and then when you come to when there is a conflict, it goes into a third or a human reviewer, where this case is then reviewed and a clinical decision is being made. I think some of those trials has been in Australia and other places. But I think what has been very interesting is because all of us are grappling with these problems. And as well in Toronto, there has been a lot in SEMLICs with respect to algorithm, Dr. Mohammed Mamil and others who have really been doing fantastic work in terms of like implementation of algorithms and learning. But I think what we have realized and came across is that implementation has different stages, and we need to have a unified set of benchmark standards so that we are able to benchmark and say this algorithm performed at Stanford, it's deployed in Toronto General or SickKids, and it's performing similarly, or it's provided in Australia, and it's kind of compare. How do we compare algorithms across different sites? We don't have metrics and measurements. What are the sorts of questions do we need to answer for any algorithm that are being deployed? So it has been really impressive to see the Coalition for Health in AI at the CHI come together to bring people from government, from across the different sectors, to think about what are the different standards that we should have across each of the stages of the AI development, and what sorts of checklists or questions people should ask themselves when evaluating or when building. So this is something that's really has been a huge effort, and should it's exciting to seeing this coming out soon. But I mean, like, this is the future where we will need to, again, going back to organizational readiness, we will not only need to share, we need to share the knowledge of what we learn across the different academic institutions and what deployment looks like, what failures look like, and almost develop best practices of really how really things fail or succeed in environments. A lot of this require implementation science, which is a lens that we have not really been focusing on so much, but is going to be in critical need to understand what makes an algorithm work in environment A but fails in environment B. Where are those human factors? Where do you build safeguards in order for the model to be successful? So I think these are some of the questions that we're still, as a community, healthcare community, are still trying to kind of nail down.
Yeah, I'm glad you mentioned Chai. I mean, that's obviously an organization that's just been formed, and I think will have huge implications in the work that we do in healthcare and AI. Would you mind telling us a little bit about those assurance labs that you were talking about earlier, offline with us, in terms of how Chai plans to bring things together in different hospitals and networks together to actually make this implementation of AI in healthcare a bit more seamless and streamlined?
Yeah, and there has been a publication on that in JAMA with Nigam Shah and others. But I mean, the main component here to think of assurance labs is we have a problem of algorithms or clinical decision supports only being. So if you think about it, many people think once the FDA has cleared an algorithm, the algorithm is can be marketed, but is it safe to use or not? And so the assurance lab is a way where you have people who have developed those standards across the different stages. Let's say you want to deploy an algorithm in your context. You can ask the vendor, or you can submit your own algorithm to that assurance lab to kind of validate how fair is it, how reliable is it, how does it perform to a hold on test set, like what is its robustness and fidelity. So these are questions that we have no metrics for. You can think almost as if, like Chai is serving more of an organization where there is that collective knowledge and infrastructure to be able to realize how do we identify algorithms of good quality that are ready for deployment. And I think this is something that's going to be growing, but it's certainly that, labs that have data about that and have infrastructure where algorithms are being developed and compared, this becomes public information. Or I can't speak really if it's going to be public information, but it provides you with assurance certification of the quality of the algorithm that's in question. And so you can think about that as, if you're a healthcare developer, you have a metric of whether you should invest in it. It's investment has risk taking component to it. So how much risk are you putting in investments in algorithm like that? So I think this is where that potential is going to come. And I think there is a lot of still efforts about how setting up those infrastructure across assurance labs is going to look like.
Yeah, so that was very thought-provoking, and it definitely is something that a lot of sort of like AI, artificial intelligence builder in the healthcare space, and we definitely need to think about, and you touched upon, the risk factor of, and which I think a lot of people are very optimistic about, integration, but then some of them neglect the risks involved, but it's definitely something that we have to think about. So I want to touch upon sort of the last bit of our conversation here, which is your personal insights into sort of your personal research and your future direction that you would like to, talk about, sort of like why you're doing this research in the first place and where you'd like to take this research to, and ultimately what you like to achieve out of the research. So yeah.
Well, these are good final wrapping questions. Well, I think why I'm really doing this research is just, understanding the fundamentals of and potential of AI. I'm really I'm really interested to see AI being implemented for the good, recognizing, like I migrated to Canada and North America, and, I recognize where I can go wrong and where some communities might be hurt. So I feel having the safety and robustness of AI is something that's I think about all the time, and how really can we make it accessible is something that is important that we have still to make huge efforts on. Where I would like to take my research, I think my experience in Stanford has been fascinating in the ability to learn about, there is, if you think about it from a meta organization level, there is knowledge about, what are the best practices to develop, robust methods for image segmentation, for compression of images, yet not losing data, building reliable, robust models, large language models, you frame it. So this is the category of the tools we have been developing. And then you also get to learn about, what are the different challenges that we face to get good data, to build good models? And at the higher level, how can we address the organizational barriers that impedes either AI development, sharing, or like development deployment? And so this is like the way of knowledges I have been kind of trying to think about. And I think one of the main component is really how do you train people to think from a different paradigm about really, what is the technology we're developing, what's its use, how are we kind of like implementing this technology. So that's where it has been. I feel where I want to take my research is, I really, as AI gets deployed into clinical settings, I'm really interested to understand where human and AI are going to collaborate, and where there could be blind spots. I put on my cognitive science hat, being trained at the Wilson Center at the University of Toronto, medical education, with Dr. Maria Malopoulos and Nikki Woods. It's really fascinating to understand cognitive biases and where, how can we be very susceptible to these biases, and where do we put safeguards against that. I have been doing a lot of work on the ethical and governance of models based on the risks. And so I want to continue working on that, not to be a roadblocker, but actually to collaborate with technical teams to share that knowledge. Because one of the biggest barriers has been that, we always do our research in silos, and that interdisciplinarity is almost a challenge. And so how can we, as people who understand the ethical and clinical need, work with the technical teams to understand how to better define that in terms of code, in terms of algorithm development and product we are getting. And the final question was what?
Well, it was about ultimately what you want to get out of this, but I think you've pretty much answered it in your previous answers, in which you want to, do the better for healthcare with, reduction in bias and with the betterment of, integration of AI technology. And we always like to end our podcast with two very intriguing questions. So the first question is, what is the one thing that you're particularly excited about in the future of AI in healthcare in 20? There's only one thing that you can talk about.
I know it. I know it. It's the virtual reality of using Apple Pro Vision. Like, I don't want to be funny,
Nice.
but I mean, like, it's very exciting to see this in medicine, and the potential to use this in medicine to learn, to work, is just like fascinating to me. That I feel like 2024 is going to be a year of strides for these type. Like, initially, wasn't really thinking a lot about the impact of virtual reality, but I have changed my mind. So this is the one thing I'm working for.
Okay, I had a brief conversation about that and the potential of, surgery training with Apple
Yeah.
Vision Pro. It's very fascinating. Now, we've talked about the excitement. What is the one concern that you have, the biggest concern you have about this technology, or not particularly, just VR technology, but AI and the future of healthcare technology in 2020?
That's a good point. Okay, so I think my biggest worry is how scalable, like the algorithms and large language models are being built, but how are users educated about the use of those? So my biggest concern is that there's a lot of generative AI health products that has been coming into the market, approaching physicians, approaching patients, yet we know very little about the risks and how their data is going to be used. And so I feel number one risk is really we have not been educating the public enough around the risks of these tools and how they should question these tools before using them.
Absolutely. I'll pass the mic to Samir for the final words.
Awesome. That was a really amazing conversation. Thank you so much, Dr. Alaa, for coming onto the podcast, sharing your insights, talking about your paper in JAMA, and just your thoughts around AI and healthcare. That was very beneficial for me, and I really hope our listeners enjoyed it and got all the pearls that you were able to deploy for us. So thanks again for all your time and for joining us on the podcast. Michael, as always, good for us to connect, and we look forward to having these conversations about AI and healthcare in the future, and we hope that it leads to a better, a safer, a more ethical use of these tools, and that it actually helps physicians, clinicians, and patients worldwide. I think that's something Michael and I have always been really excited about, and what had this entire thing started off was just our passion for making sure that the tools that are coming out are used in the best and safest way possible. So thanks again for joining, and thank you so much, Dr. Youssef, for your time. It was honestly an honor and a pleasure.
I really have to thank you both because I really enjoyed that conversation so much. And I feel, like it's almost like I can go on for hours talking about so many different interesting things. And I think our talk shows how scientists, computer scientists, clinician, we have a very interesting conversation together, from ethics to computer science to algorithm to medicine. So really, I'm really commending you on this initiative, and look forward to hearing more about future episodes.